Hey everybody, my name is Eugene Loxton, and today I'd like to discuss the injury, the Achilles tendon rupture. We typically find this within athletes, but it can happen to anybody, and I'd like to discuss the structure and function of the Achilles tendon and a treatment plan, as well as a hypothetical situation for the rehabilitation of an Achilles tendon rupture. So what is the Achilles tendon? A tendon is a group of fibrous tissues that connects muscle tissues to bone. The Achilles tendon is located on the posterior side of the lower body, inferior to the knee joint and superior to the heel bone, also known as the calcaneus. It is easily observable and easy to palpate under normal circumstances. It originates from the combination of both the soleus tendon and the gastrocnemius tendon, the muscles responsible for plantar flexion of the foot at the ankle, and inserts distally to the calcaneal tuberosity. A neat little fact that I learned while doing this video is that the Achilles tendon is the largest tendon in the human body. Here we have a picture showcasing the posterior side of the lower leg. On this picture you can see where the gastrocnemius muscle is actually over top of the soleus muscle, but how they both converge together to form the Achilles tendon. Now with the gastrocnemius muscle, you have the medial head and the lateral head, which will be discussed later. Here's what dorsal and plantar flexion look like. On the right side of the photo, you have plantar flexion. Plantar flexion happens when you contract your gastrocnemius and soleus muscles and push as hard as you can down to the floor into your toes. You'll be able to stand up on your toes. Dorsiflexion is the opposite of that. It's pulling the toes closer to your body on the anterior side. So how does an Achilles tendon rupture? Well, it happens most frequently, as I said before, in individuals who are participating in athletic activities. However, any external or internal force that causes the Achilles tendon to overstretch is more likely to cause a rupture. Here's the hypothetical situation. College offensive lineman named Mark. While leaning forward to prepare for contact with the opposing team's lineman, upon collision, you see Mark get completely overwhelmed and go down. But when the play is over, Mark tries to stand and falls over. You as the trainer / coach or athletic trainer certified, etc., bring Mark off the field, so what happened? Beginning the injury assessment, these are the things you could possibly look for to determine whether or not Mark actually does have a ruptured or torn Achilles tendon. The athlete may have heard a popping sound when it happened. The athlete will either be partially or completely unable to plantar flex. You may be able to observe the remainder of tendon and muscle tissue bunched up and appearing to be a knot under the skin, kind of like a rebound effect. Once the tendon is tore, the muscles actually pull back since there's nothing holding them to their attachment point. The athlete may experience moderate to severe pain and swelling near the heel. The athlete will not be able to stand on his or her toes on the injured side. So back to what happened with Mark. After learning that the Achilles tendon had indeed ruptured in Mark, you question Mark on what he recalls of the event. Mark claims there was an issue with his footing. You inspect the field and find that where the back of Mark's foot was planted was a moderately sized depression in the ground, creating a kind of pocket his heel must have sat in when he took contact. The conclusion that you come to is due to the depression in the ground at Mark's heel, his footing placement pre-exposed his Achilles tendon to be in an overstretched position before the opponent's force was applied. Once he received contact with the opposing player, the amount of instantaneous change to force being applied to the vulnerable area was too much to bear, and the rupture occurred. So as far as I'm concerned, and as far as some of the medical bodies that govern this industry are concerned, the precautions I would take to prevent the injury reoccurring, Well, the circumstances of this injury, I would probably locate field maintenance services to ensure the safety of the field for my players, including the leveling of ground prior to any practice or game on the home field. Then I'd conduct an education seminar about this particular injury that was experienced, how it happened, and what the athletes should look out for in the terrain and good footing placement. Then I'd put Mark through extensive rehabilitation, not only for his physical performance, but psychological performance as well. If the athlete needs surgery, then that will occur before physical therapy begins. Okay, now we're going to talk a little bit about the rehabilitation and recovery that's in store for Mark. So we have some options. That would be surgery, stem cell therapy, which some locations I know do not offer this. It may be available in your area, it may not, but if it is, it's definitely worth looking into. Then you have the normal casting or immobilizing the ankle, which you typically see around the workplace after an injury has occurred. Physical and occupational therapy. So we're going to discuss each one of these as we go in. So for surgery, the big point that I want to make is that there are two types of surgery. There's open surgery and there's percutaneous surgery. With open surgery, the surgeon makes a large incision in the back of the leg for the Achilles tendon. With percutaneous surgery, the surgeon makes multiple incisions rather than just one. That's pretty much the only difference between the two, because in both the surgeon is attempting to reattach the Achilles tendon to itself. There's a few cons, there's a few pros with this type of approach. First, we're going to go with the pros. The success rate of recovery has been shown to be between 80 to 100% after a surgery, where the patient was able to return to previous activity they were participating in. We got a couple cons coming up here. They happen from time to time. First, we have risk of infection at site. Up to 6 months to recover from surgery. Normal complications of surgery, poor reactions to anesthesia, profuse bleeding or even reoccurring bleeding at the site, and side effects of medications. You could wind up with nerve damage, but your Achilles is torn, so it's probably already got some damage going on in there. And decreased range of motion. However, the range of motion that you will most likely observe after in post-surgery and rehabilitation is still going to be better than pre-surgery. Next treatment option we're going to talk about is the stem cell treatments. So stem cells is new to me, and I just recently learned that these are available treatments. And they're really neat. Stem cell is part of the umbrella term of biologics when it's used for injury treatment. So what they say is they say that this is being treated by biologics, which would be treatments aim to restore the normal properties of the native tendon and reduce risk of re-rupture. The risk of re-rupture comes partly from the fact that as the tendon heals, it forms scar tissue, which will be less mobile and flexible. Using stem cells injected into the injured area, the stem cells grow at a rapid rate, forming more stem cells and trigger the body's natural growth hormones to eventually lead to forming into and joining with the current organ in this case, it's the Achilles tendon. This can be very powerful when used in conjunction with surgery and physical rehabilitation. So the steps would be most beneficial would be to, if you need the surgery, to get the surgery. Then you want to go ahead and see if stem cell is an option for you during your recovery process. Next, we're going to go ahead and talk about immobilization and casting of the injured area. So it's recommended that after this particular injury, the area be immobilized in either a full cast or in a cam walker boot. The intent is to protect from further damage so the area can reduce in swelling and begin the healing process. Your podiatrist, primary care provider, and surgeon can use their expertise to determine the length of time required in the cast and any follow-up physical therapy that is needed. We're hoping for not a lot of time stuck in the cast, because now you're talking about work time, recovery time, etc. The next step we're going into is the physical and occupational therapy process. Your treatment team will determine what specific plan is right for you. The idea of the program is to exercise the injured area to stimulate new growth and strengthen the existing structure. The goals are to increase stability, range of motion, and strength to pre-injury, if possible, ability. What we're going to talk about here would be the typical exercise prescription that I have seen the most effect with, as well as studies are showing comes very effective. So the activity is combined of 3 different stretches and 4 different exercises, 2 times daily, with repetitions of 3 times per set or 10 times per set, respectively. So first we're talking about stretches. We're going to go through the standing calf stretch, the standing calf stretch for the lateral head, which is one of the heads we were discussing earlier, and the standing calf stretch for the medial head. We also have 4 exercises following that. They're all requiring an elastic band, which most physical therapies, if not physical therapy offices, if not all of them, carry these, and they're relatively cheap to get a hold of. So we're really not looking at too much of a difficulty finding this particular tool for our exercise. So let's begin with stretches. First, we have the standing calf stretch. Now, what I want to point out here is that the following calf stretch positions are just about exactly the same as this first one here, with minor alterations to the position of the back foot that you're stretching. But for all intents and purposes, you will be standing, arms out forward, holding the wall. Place the leg to be stretched back about 1 foot. I want to point out a little difference between, how far should you put your foot back. I suggest starting about 1 foot, and then slowly progressing that back leg farther. Now you'll feel a bit more of a stretch the farther away you place that back leg, as well as the more you bend at the knee in the front leg. I never want, you never want to stretch into pain. All physicians agree that stretching into pain could cause, more injury to the area. You don't want to injure more of the area. So what you want to do is you want to gently bend the front leg at the knee, keeping the back foot planted, and continue bending until you feel a slight uncomfortable stretching of your calves. See, that's what I'm talking about here. Just a slight uncomfort. You'll know the difference between is it just uncomfortable or is it painful, and you never want to stretch into pain. So you're going to hold this position for 30 seconds, feeling that uncomfortable stretch, and then you're going to relax, and then repeat the process 3 times, 2 times daily. Next, we have the standing calf stretch, lateral head. Now, I wanted to go ahead and put in this first picture here showing the toe in versus the toe out. For this particular exercise, we are going to want to gently externally rotate or point your toes away from your body for your back leg at the hip. So when we're talking about pointing your toes away from your body, let's go ahead and look at the picture toe out. Okay, you see how his toes are pointing to the outside of the center line of his body. We'll take that position, we apply it to the back leg. We externally rotate our foot outwards so the back foot toes are pointing away from the center of the body. You hold this position for 30 seconds, repeat it 3 times for 1 set, and you do this twice daily. Following, we have the calf stretch for the medial head. It is, in fact, the same position as the first stretch. You have to gently internally rotate or point your toes towards the center of your body, as seen in the first picture on the left side where it says toe in. You see how the toes are actually pointed towards the center of the body on that one. You're going to hold this position for 30 seconds, repeat 3 times for 1 set, do this twice daily. Now we're getting into the exercises, which are particularly neat in how we do this. So we get ourselves an elastic band, and we're going to do inversion of the foot first. So what you want to do is you want to get seated. You're going to cross your legs with an elastic band wrapped around one foot, whichever foot is injured, whichever foot you're trying to rehabilitate. I would also suggest following this up with doing it on the other foot just to stay even. But so you're going to cross your legs, elastic band wrapped around one foot. Then you're going to hook it under the opposite foot, as you can see in the picture, and take the end of the band and place it in your hand. Now you're going to want to keep your heel in contact with the floor, and then you're going to invert your foot and relax. Every time you invert your foot or you point your toes to the center of your body, you are pulling on that band and you're actually strengthening that area. Now you want to do this one twice daily for 3 sets of 10 repetitions each. And that goes the same for every exercise we are going to go through. Next we want to talk about elastic band eversion. So it's essentially the same thing as the first one, but the only difference is you're wrapping the band around one foot and you're turning your foot in the opposite direction. You're going to want to hook it under the opposite foot and bring it up into your hand. You're going to keep your heel in contact with the floor, then you're going to evert your foot and relax. Twice daily, 3 sets, 10 repetitions. Following, we now move into a different plane of movement. We have elastic band plantar flexion. You're going to be doing this while you're seated. The elastic band is hooked underneath the balls of your feet. You're going to press down on the band with your toes and then relax. You're going to do this twice daily, 3 sets, for 10 repetitions each. And then the opposite muscle action, you're going to do dorsiflexion with the elastic band. This one you're also going to do seated. In this particular photo, the elastic band is looped around the top of the foot, and the opposite end is either held by the physician or trainer or is firmly secured around a preferably immobile and very heavy object. You're going to pull up on the band with your toes and then relax. Same prescription here, you got twice daily for 3 sets of 10 repetitions. And that wraps it up, everybody. I really appreciate you guys giving me the time to go over this particular injury. This injury means a lot to me. It's something that I've suffered with myself and am still actually currently working through rehabilitation. So I just wanted to send out good vibes. You know, you get this injury or somebody you know gets this injury, here's a little handy guide that might give you some good education. So thank you everybody again. My name is Eugene Loxton, and this has been a presentation on the injury Achilles tendon rupture.